Hello, and welcome to Med School Tutors 15-minute question dissection. My name is Ken Rubin. I am one of the senior medical instructors with Med School Tutors. Hello, and welcome to Med School Tutors 15-minute question dissection. My name is Ken Rubin. I'm one of the senior medical instructors with Med School Tutors. I'm also a graduate of the ICANN School of Medicine at Mount Sinai in New York City. We're very pleased to have you with us for this next in our webinar series, where we dissect a particularly high-yield USMLE Step 1 question, analyzing the vignette, looking at the answer choices, and talking through the relevant content. Just as with other webinars, the format will be a case dissection followed by a proposal of additional questions that would be relevant for a full discussion of the topic, but that go beyond the scope of our time tonight. And then at the end, we'll give you more information about Med School Tutors and let you know how you might want to take the next step in terms of pursuing tutoring. Without further ado, let's get started. Okay, so here's our case right here. Before we read this case, let's first address a question that many students have about how to approach a USMLE style question. Many students wonder if it makes more sense to read the vignette first or to look at the answer choices first. And the reality is there is no one right way to do this. In many cases, it can be helpful to take at least a little quick peek at the answer choices just to give you an idea of what type of question you're dealing with, whether it's a cell biology question, a biochemistry question, or a much more clinical question. In this case, it does help us to take a quick look at the answer choices. In doing so, we see, in fact, terms like apoptosis, necrosis. This tells us that we will be dealing with a general pathology question, and that orients the way we start thinking about this. All right, let's start reading the question together. A 28-year-old male IV drug user presents to the ER with fever, right upper quadrant pain, abdominal pain, jaundice, and anorexia. And we're going to stop there. It's very important when reading through a USMLE style question to not get ahead of yourself. So much information is contained within that opening line, from age, gender, presenting symptoms, and a lot of that information can be used to start generating a differential diagnosis, which is a big part of what we like to do with students. So in this case, we see that the patient is 28 years old, which is young. Makes us think that there are probably not a lot of other comorbidities going on, so any process that might be going on in this case is likely acute and not chronic. That's an important distinction. We also see that the patient is an IV drug user. Common patient presenting on one of these USMLE questions, and so immediately we want to think a few things. We want to think possibly an infectious etiology, bacterial versus viral, perhaps bacterial endocarditis in an IV drug user, perhaps HIV infection, and additionally we have hepatitis. All of those are possibilities that we want to be thinking about from that opening information, IV drug user. So what else do we see here? Well, we see that the patient presents with the right upper quadrant pain, and we know that's where the liver is, also with general abdominal pain, jaundice and anorexia. And when you see jaundice and right upper quadrant pain, immediately you want to think some liver process. So already we're thinking perhaps acute hepatitis. And so at this point you'd ask yourself, well, what are the different types of hepatitis infections, A, B, C, D, and E, and which ones would be more common with an IV drug user? That's a relevant point. So now let's read on. We have LFTs reveal an AST of 450 and an ALT of 473. So we remember that the AST, the ALT, these are the so-called transaminases. These are enzymes that are contained within the hepatocyte in the liver. And as long as the integrity of the membrane is intact, those enzymes should be relatively low, under about 25 to 30. So when we see this elevation here, this tells us that we have an acute process in the liver. You can do a thorough discussion of LFTs, depending on how high they are. That's beyond the scope of what we need to talk about here, but we do see moderately elevated liver enzymes reflecting hepatocyte damage, and that is consistent with an acute hepatitis infection. So we read on. We see that liver biopsy reveals mononuclear cell infiltrates, hepatocyte swelling, and acidophilic bodies. There's a lot of information in that line right there, and we need to understand what these terms mean. First off, we can note that a liver biopsy was done, and if we are thinking that this is a type of hepatitis, liver biopsy is not vital to be done in the diagnosis of hepatitis, but it is done here, and we have information, so let's analyze it. First thing we see is the mononuclear cell infiltrates. So often a term like that, mononuclear infiltrates, is just glossed over by a typical student. We see those terms so often, we don't really think what they mean. But let's understand what that means. Mononuclear cells typically refer to monocytes. Monocytes are the blood equivalent of macrophages. Monocytes in tissue become the macrophages. So we're talking about a macrophage infiltration here. Also, mononuclear can refer to lymphocytes, specifically T lymphocytes. So already we know from that one term that we're dealing with perhaps T lymphocytes and monocytes macrophages in our liver, and that's important to keep in mind. We're also told that there's hepatocyte swelling, and we want to ask ourselves, what is the basic mechanism of swelling in ischemia that relates to sodium-potassium pumps and ion flow and water, beyond the scope of what we can go into now, but that's a very essential point for step one. And also we have acidophilic bodies. Now, this term may be the most confusing to most of you out there, so of course that is what the question will be asking us. The question is, formation of acidophilic bodies is a result of what? So without going into what this is now, we're going to come back to this a little later. Okay, so before we do a full analysis of this question and try to get to the right answer, let's do a little bit of a review of liver in general. And we're going to look at the liver from a gross perspective. We're also going to look at the liver from a histological micro perspective, and we're going to review a little bit of imaging that is relevant for any type of USMLE liver-based question. So here we have progression of liver damage. On the left, we have what is a normal, juicy, healthy liver. All the way on the right, we see diseased liver, a cirrhotic, fibrosed, nodular liver, and we see the progression as we go from left to right. Acute damage would cause what we have over here. The chronic liver damage would be more on the right. And already from our analysis of the vignette, it seems like we're dealing with an acute situation. So if it is hepatitis, we'd be wanting to understand acute hepatitis, but you can never really understand acute of a disease unless you understand the chronic as well. You need to understand the distinctions. So what we're going to do here is first review chronic. This is a little, before we do that, this is a little more blown up picture here. We have the normal liver, we have the architecture inside, which we will also review, and then at the bottom here we see very clearly this fibrosed nodular liver. This would be the end-stage cirrhotic liver that is irreversible. Okay, so if we're going to talk a little bit about chronic liver disease and cirrhosis, we want to understand one of the most common complications of that, which is portal hypertension. Now, portal hypertension is an extremely important topic for all steps of the USMLE, including step one. So this is a typical CT scan that you might see, that you might be presented with in portal hypertension. So what do we see here? We see a lot of things. One of the first things we see is all the way on the left, or actually we should say the left side is really the right and the right is left. We remember that scans are reversed in imaging, CT imaging. So we see this peripheral rim of density, or this fluid, and what is that? Well, that's ascites. Remember why there's ascites, hydrostatic pressure, oncotic pressure, all of those terminology, very, very important beyond the scope of what we're going to talk about here, but you want to understand why you see ascites and these other sequelae. So now we have the ascites. We also see here this big structure here. So this, of course, is the liver itself, and this is the cirrhotic liver. You see a little bit of white, a little bit of nodularity in there. Hard to interpret these scans without having a higher level radiology knowledge, but we can make strong inferences based on what we know. And what else do we see? So we look at the right-hand part of the screen, which refers to the left part of the body. We see this huge structure here, and this is the spleen. So what we see here is splenomegaly. You want to ask yourselves, why would you see splenomegaly in cirrhosis and portal hypertension? Again, this relates to primarily the hydrostatic pressure, and many other topics in USMLE will come down to hydrostatic versus oncotic and things like that. Okay, so now there's one more structure that we're looking for here. We see in the middle of the image these tubular structures with the dense material on the inside, and we don't really know what these are. Again, we don't have upper-level radiology knowledge, but the important point here that will be applicable to us answering our own case, in this case, is how to make strong guesses based on our clinical knowledge. If we're thinking that this is portal hypertension, that this scan here is referring to portal hypertension and cirrhosis, and we know that one of the most common complications of portal hypertension is esophageal varices, the dilated systemic esophageal veins, then we can make the strong guess that these tubular structures are varices. So again, we don't have to have upper-level resident or attending knowledge of radiology to be able to figure out what these scans are showing us, and that will hold true for histological images as well. Okay, great. So now let's take a look at the liver on a more micro scale. So we've seen it from a gross perspective, we've seen it from a imaging perspective, and now we're going to look on the micro level here. So what we're presented with is the liver lobule. And you see here that this lobule is a hexagonal figure, and at each vertex of this hexagon, we have what's called a portal triad. And there are three important structures that run in the portal triad. We also have these strips of little cubes. That's how they look on this image. These, of course, are the hepatocytes, the liver cells, where all the key processes of the liver occur. And then in the middle, we have this structure over here, this is the hepatic vein, and we're going to talk about in a second how everything flows. So the first structure for us to talk about is the portal vein. That's one of the key vessels in the portal triad. We know the portal vein and its tributaries deliver blood to the liver from the gut for cleansing, detoxification, and other processes. And so the portal vein starts on the periphery in this peripheral zone of the liver, and branches of the portal vein will run towards the middle, will radiate towards the middle, where it will feed the hepatocytes, and then eventually that blood will end up in the hepatic vein, which is the structure over here. So this is the centriacinar zone. This is the centriportal zone. This is the peripheral zone out here. Portal blood will run from the periphery into the central area. All right, so what other structure do we have? Well, we have the hepatic artery. So also in the portal triad, we see this hepatic artery. Hepatic artery is delivering fresh arterial blood to the hepatocytes, which they need. And this presents a very interesting and relevant point for the USMLE. The liver has what's called a dual circulation. The liver is fed by both the hepatic artery and the portal vein. Well, why is that important for us? It's important because tissues that have dual circulations are less prone to ischemia and necrosis. That doesn't mean that the tissues cannot suffer ischemia and necrosis, and certainly in a case of hepatitis or other liver infection, you can see ischemia and necrosis. But this idea is important, and you'd want to ask yourself, is there any other tissue bed in the body where we have this setup? And the answer is yes, in the pulmonary circulation. You may remember that we have the bronchial arteries as well as the pulmonary arteries, and that too is important. That makes the pulmonary circulation less prone to ischemia, and the USMLE will test connections like that, so very important to understand. So the portal vein, tributaries of the hepatic artery will course from out to in, passing through the hepatocytes that we have. And we also have the hepatic vein, which you mentioned before. Hepatic vein is the repository of all of this blood flow. All of the key enzymes and proteins and metabolites that are produced in the hepatocytes will end up in the hepatic vein. And that is true for most tissues, that most of the hormones produced or substances will leave the organ via the venous system. In the kidney and adrenal gland in particular, that's true. And then the final structure that we have, the bile ducts. We have these structures over here. They make up the third vessel or the third structure in the portal triad. The bile ducts are interesting because they run in the opposite direction. They run from inner to outer. Remember that the bile is synthesized in the hepatocytes, these cube structures over here, and then that bile will be drained via the biliary canaliculi, these little canals, and will end up in these intrahepatic bile ducts in the portal triad. And then from these ducts, we go to larger hepatic ducts, eventually common hepatic duct, eventually common bile duct, and then drained into the gut. So what happens if we have obstruction, if we have fibrosis, nodularity, resistance to flow in this hepatic lobule? Well, that's exactly what we were talking about before. That is the portal hypertension that causes all the sequelae, the ascites, the esophageal varices, and in that case, we're going to have a shunting of blood, and that's what's depicted here. We're going to have blood passing from the portal vein, portal circulation into the venous circulation without being detoxified, and that leads to other problems that are beyond the scope of what we're going to talk about here. Okay, so now that we reviewed chronic, let's talk about acute damage, because that is what we think is going on in our case. And so what we're going to do here is look at each of the answer choices and try to understand what the answer choices are talking about. So the first answer choice that we have for what might be going on in our acute hepatitis is hyperplasia. If we look at the histo slide here, we see a few things. We see some mitotic bodies inside of these cells. It's very hard to interpret a slide like this. But if we do see hyperplasia, we recognize that it's due to a hepatocyte response to the loss of neighbors. The liver is one of the tissues that is able to replace damaged cells. Not all tissues can do this. You might be thinking about muscle cells, especially cardiac muscle, neurons, brain cells. Those cannot be replaced, and while other cells can. And then another link to make with hyperplasia is adrenal hyperplasia. This is a very important, commonly tested point on the USMLE, that in an excess of ACTH, that will stimulate the adrenal gland to become hyperplastic, to grow more cells, instead of become hypertrophic. Hyperplasia versus hypertrophy, important to keep that straight. So the next answer choice that we have is pigment accumulation. And when we think of pigment in the liver, thinking about a few things, or pigment in general. We think maybe about iron accumulation, as hemosiderin. We also think about wear and tear, the so-called lipofuscin pigment that older tissues can develop. On this slide, we see a little bit of this yellowing over here in certain areas. That can be lipofuscin right here, and right here. And in the liver specifically, though, we want to think about the cells that pick up this debris, and those are the Kupffer cells. So we mentioned before that we have a monocytic infiltrate, and monocytic refers to monocytes or macrophages. Important to remember for the USMLE that in the liver, those macrophages are called Kupffer cells, and they are going to be actively involved in the process that's going on. Also, we want to think about Langerhans cells in the skin. Those are the antigen-presenting cells and macrophages that are active in the skin. Our next choice begins a series of types of necrosis. So here we have liquefactive necrosis. And on the right, we have the gross image in the brain slice. And on the left, we have histologically what liquefactive necrosis looks like. Importantly, liquefactive necrosis is the CNS type of necrosis. It is the only type of necrosis, of irreversible, messy cell damage that we see in the brain. And the reason for this liquefied consistency is the heavy myelin, heavy fatty content of neurons. What happens is the lysosomes in neurons and brain cells get spilled. The enzymes get spilled out. Those enzymes will hydrolyze a lot of the surrounding tissue, including a lot of that myelin, that fat, and that creates liquefied consistency. On the USMLE, if you see liquefactive necrosis, immediately you want to think brain necrosis and brain damage. So the next type of necrosis we have is fibrinoid necrosis. So fibrinoid necrosis is a specific type of necrosis that we see in vasculitis. It has to do with antigen-antibody complexes in the walls of arteries that triggers antibody and complement responses and deposition of fibrin, the blood protein that comes from fibrinogen in blood. And when you see fibrinoid necrosis, you think vasculitis. Specifically, you think polyarteritis nodosa, a classic transmural necrotizing vasculitis. Interestingly, polyarteritis nodosa has a 20 to 30% association with hepatitis B. Hepatitis B being one of the key blood-borne hepatitis infections that could be affecting a patient like we have here. So on the USMLE, you want to remember associations like that. Often in a patient with polyarteritis nodosa, there will be hepatitis. You have to be looking for that. So let's look at two other types of necrosis. The first type we have is coagulative, and the second type we have is caseating. So coagulative necrosis is a very common type of necrosis, very commonly tested type of necrosis that we see in end organs. We see that type of necrosis in the heart. We see it as wedge-shaped infarcts in other organs like the spleen, like the kidney, even the pulmonary tissue, even the lung. And we see this wedge-shaped band of tan tissue here represents irreversible death of myocardium. We also notice something interesting about this gross specimen. We notice how thick the heart is. We see how hypertrophied the heart is. So we could think, well, this patient, whoever this patient was, this patient probably had a hypertrophied heart, probably a chronic hypertension, aortic stenosis, probably an older patient. Those are the patients more prone to infarcts anyway, so the picture makes sense. You always want to make sure the picture makes sense. This last type of necrosis that we have is caseated necrosis. Just like liquefactive necrosis, caseated necrosis is very specific for a certain disease, and that disease is TB. TB, we get this cheese-like consistency that comes from all of the macrophages forming collections and granulomas. These are the so-called caseating granulomas. And we get this cheese-like consistency of the tissue, and you will only see that in TB. And if you remember that, you will get that question right on the USMLE. Of course, anytime you think of TB, you want to ask yourself, well, if TB is related to caseating granulomas, what are non-caseating granulomas involved in? And that's an important question that you'd want to think about. Finally, we have the choice of apoptosis. Apoptosis, as opposed to necrosis, is the so-called ordered cell death, where cells commit suicide or they're triggered to die. What we see initially are these large cells with hyaline material in the middle. Over time, those cells will shrink, and we see ultimately shrunken eosinophilic cells. These are also called Councilman bodies, an important term to remember, and something to keep in mind and as we explore what the answer can be to our question. And of course, we'd also want to consider Fas ligand. Fas ligand, along with perforins and granzymes and calcium and caspase, these are all important components of the apoptotic pathway where cells are triggered by the immune system to commit suicide. So you want to recognize terms like that on the USMLE. Great. So now we're back to our vignette. We have a much better understanding of these answer choices. Many of you might think you know what the answer is, but it's still not completely clear. What are acidophilic bodies? How will we figure that out? One way we can do that is by stratifying or organizing the answer choices. We talked about hyperplasia and pigment accumulation. These predominantly are chronic changes that we see. It is true that you can get some pigment accumulation, some debris in an acute infection, acute hepatitis, but typically on the USMLE these are more chronic changes, and our case we said is an acute presentation, and that distinction alone is enough to say that maybe A and B are not going to be the correct answer. Now we look at choices D, E, F, and G. These we said are all necrotic changes. Is it possible to have some degree of necrosis in an acute hepatitis, hepatitis B, or hepatitis C? Absolutely. You're going to see necrosis in the tissue, but we know a little more. We know what each type of necrosis presented here refers to: brain, vasculitis, end organ damage, TB, and none of these types of necrosis matches up with acute hepatitis, acute liver damage. So by that we can say probably not the answers. Of course, that leaves C, apoptosis, as the answer choice. And so this is a good example of how we can use process of elimination on the USMLE to figure out questions that are difficult. It turns out these acidophilic bodies are the so-called Councilman bodies, as we reviewed before, but you did not need to know that. We did not need to know that to figure out that the answer was C. Now, some of you out there might be asking yourselves, okay, that's fine, that's a good strategy. Is there another way that I could have figured out that, taking the test, that the answer is apoptosis? And in fact, there is. The more understanding that you have of different systems, the more integrative understanding you have, the more you're able to apply that understanding to unfamiliar vignettes like the one we have here. What I mean by that is think about what triggers apoptosis versus necrosis. We've said a number of times that necrosis is the messy cell death. If you have sudden ischemia of a tissue or toxic damage, that can lead to acute breakdown of the membrane, release of all the enzymes, and a messy death. Apoptosis, on the other hand, is immune-based. Whenever the immune system activates the death pathway in the cell, we get this ordered apoptosis. So that gets to the fundamental question of what is the mechanism of cell damage in acute hepatitis, which is something we haven't spoken about yet. An important point for the USMLE is that in acute hepatitis, the damage we see, the high LFTs, the jaundice, the anorexia, the right upper quadrant pain, stretching of the capsule, all the stuff we see, that is due to T-cell mediated damage of hepatocytes. It's not the initial viral cytopathic effect. And in fact, viral cytopathic effect, that is specifically the terminology of the NBME, of the USMLE. It is not that. It is the virus will incorporate itself into the nucleus, and it will cause a latent infection, but it's more so the cytotoxic CD8 T cells that recognize these virally infected healthy hepatocytes, formerly healthy hepatocytes, and trigger an immune response, and that's what we see. So we have virally infected cells, we have cancer cells, we have graft cells. All these cells are going to be targets of the cytotoxic cell-mediated immune system, and that type of question will show up again and again and again on the USMLE, and you need to understand that. So based on that, we can infer that in this case, sure, this would be more of an apoptosis. That's going to be more of an immune response. And there are other ways as well. This just shows that you never want to give up on a question. You always want to keep your options open and use your understanding of other systems to be creative in your approach to newly presented questions. Great. So we're about at the end here. One more thing that we want to do, let's look at these images. These are the images that came up in the context of our case discussion here. You may remember some of these have to do with hyperplasia, some have to do with apoptosis, necrosis. Do you remember which image is associated with what etiology? So take a second. You've probably been looking here. And most likely you're having trouble remembering what is associated with what because this is confusing. And you know what? We would have trouble too because, again, the histology that's presented is very difficult. This takes attending level pathology knowledge to be totally comfortable with these slides, just like the radiology slides require upper level radiology knowledge, which we are not expected to have as medical students. So fine, okay, this is difficult. Well, then how do you learn this? The answer is you don't learn this. You do not want to waste your precious study time learning all the different slides, different types of images and slides, and trying to become micropathologists unless you already have that knowledge to begin with. It is much more high yield, much more efficient to interpret the vignettes and use your clinical knowledge and test-taking savvy to figure out the answer choices, just like we were able to do here. And that's a very, very important point because so much of organizing a study plan and making the most of your time is knowing what to study and what not to, and you do not want to waste your time on this. Additional questions to think about in a full discussion, which you might have during, let's say, a longer tutoring session. What are some of the complications of portal hypertension? We talked about that a little bit, but there's much more to talk about. What drugs can cause liver failure? How do we measure the synthetic health of the liver? What are the different types of hepatitis viruses, and when do you see those infections? How do you interpret laboratory results in hepatitis? And one particular important liver disease, Ray's syndrome, an important pediatric disease that we see in kids associated with a certain drug. Very important to understand all aspects of Ray's syndrome for USMLE Step 1. And now, as promised, a little more information about Med School Tutors. Med School Tutors is the leader in one-on-one medical tutoring and test preparation for a number of years now. We help aspiring physicians to do many things, to craft personalized study schedules, and very essential part of the study process. Integrating the material and balancing review with practice and Q banks and other sources. Targeting particular weaknesses. That's a major benefit of the Med School Tutors process. Everything is tailored to the student. So whatever the particular weaknesses are from the student can be focused on outside of sessions and during sessions. Importantly as well, we help refine clinical reasoning and test-taking skills. That actually is essential. One of the things that we strongly believe is that doing well on the USMLE, as important as that is, just as important is being a good clinician, understanding this material in a way that will help clinical performance down the road when all of us are seeing patients. So during sessions, we make a big emphasis on refining clinical reasoning and also, of course, helping students to approach these exams with test-taking savvy, and finally managing the pressure of intensive preparation. That is a very important thing for us to do. For more information about med school tutors, we invite you all to visit the website at www.medschooltutors.com. Much interesting, relevant information can be found there, as well as the bios of all of the tutors, so you can get a sense of who the people are you might be working with. For more information by email, please reach out to us at scorehigh@medschooltutors.com. We'll be happy to take your information and set you up with a complimentary consultation. And that's it. Thank you so much for spending some time with us here. We certainly hope that you found this case dissection useful and interesting and instructive, and we look forward to seeing you at the next webinar.